Okay, we're going to go ahead and start. So, we've been basically dealing with the cardiovascular, and we got all the way to cardiomyopathy. So we started talking about cardiomyopathy. So when we said cardiomyopathy, basically it is an abnormality within the cardiac muscles. So there are, excuse me, there are three different types that we look at. We have the dilated type, we have the hypertrophic type, and then the restrictive type. So we have it either as primary, where the dysfunction happens just as is, or secondary, which would be basically due to a different cause. Sometimes you will have this hypertrophy for an unknown reason. That would be your primary. So when it's primary, then it's an unknown reason. If it's secondary, you know it's due to some other things. And usually, many times it's due to a virus infection. So if you've been infected by a virus, sometimes you end up having one of these three different types. So let's go ahead and review each one about the most important things about each one. So if it's dilated, if you look here at this image here, the muscle the ventricle dilates. So the muscle, so you have a lot of pressure inside here that increases, that pushes the walls of the ventricle to the outside and make it dilated. So in this case, when we say dilated cardiomyopathy, we're talking about the enlargement of the ventricle here. Again, some of the predisposing factors would be alcohol toxicity, pregnancy, because you know you're requiring more blood to be pumped by the ventricle because of the pregnancy, because of the fetus. So eventually it will enlarge in the size. So post-viral, like I said, could be another issue, or genetic. So you could be having a genetic issue that can lead to that. Hypertrophic cardiomyopathy is by the, it's due to the thickening of the myocardium. So this myocardium right there becomes thicker. So when this happens, then you have limitation of the amount of blood that you have in here, and the ejection fraction, it will be a lot less. Now restrictive, if I talk about restrictive, this becomes rigid due to, some kind of disease that you get, and it will become rigid over here. So it becomes hard it's hard to pump in general. So just by looking at these different ones, you will know that which one is which. So the first one is just enlarged ventricle. This one, the restrictive is you have, hardening of this wall. The hypertrophic is just basically enlargement of the fibers that you have in the muscles. All right, so let's look at the pericardial disease. The pericardium, if we remember, it is the most outer layer that covers the whole heart. It is divided into two layers. If you remember, we have the serous, or parietal and visceral would be the serous, because they have the liquid in there. Okay, and we have the fibrous, which is the most outer. So this would be the fibrous. That's the one that is very hard. So when you get to, you probably did the dissection already, and you've seen this fibrous pericardium sitting on the outside of the heart. So the serous is just sitting inside, which is divided into the parietal and the visceral. So the pericardial fluid and the pericardial space is the basically the the space between the visceral and the parietal. So this will be your pericardial space. And many times we have extra fluid sitting in here that causes a lot of issues to the heart by causing increase in pressure. So if we have accumulation of fluid here, you're going to have increase in pressure on the muscles over here, which allows the heart to pump a little bit less. So sometimes systemic infections, trauma, metabolic derangement, and neoplasm also can lead to that. So there's one condition that you guys will be facing a lot that's called pericardial effusion. Pericardial effusion is basically the accumulation of fluid within the pericardial sac or space. So usually the pericardial space, which sits over here, it has a teeny bitty fluid lubrication to prevent the rubbing of the visceral against the parietal. But if I have a lot of fluid accumulating here, then I can have an issue, and then I can have what I call pericardial effusion. Now this is, it's very common with people that have congestive heart failure. So if you have a congestive heart failure, eventually the fluid will go from inside and it seeps out, and eventually you're going to have it lining in the pericardial space there. So this is here, this area right there, you can see that you have an enlarged heart, and you will have like a little bit, you'll have like fluid sitting in the corner here in this region right there. So, congestive heart failure patients will get pericardial effusion many times. So you could have, though, it depends on the effusion. I mean, it doesn't have to be clear fluid all the time due to an inflammation. You can have serous, which is thick. You could have seroangio, which is like a little blood in there. Purulent is just a thick type of liquid or fluid, and then all blood could be sitting in that space right there. So cardiac tamponade is, basically when you have fluid accumulating in the pericardial space that will be pushing against the muscles of the heart. Now, usually when this happens, then you have a backflow of the blood back into the right side of the heart. When you have that, then you're going to end up having what we call Beck's triad. Beck's triad, you're going to end up having a neck vein distension, hypotension because you're not pumping enough blood, and then a muffled heart sound also will be another sign of what we call Beck's triad. So these three things are significant with cardiac tamponade. Now, it's not always caused by a heart issue. It could be caused by some external trauma to the chest. So when you injure your chest in a car accident or something, you can have blood actually getting into the pericardium here, and then eventually you're causing what we call cardiac tamponade. So severe chest injury, heart attacks, underactive thyroid could be one of the signs of getting a cardiac tamponade. So cardiac tamponade is just basically that chest, accumulation of fluid that can lead to compression of the heart. So remember, there's compression on the heart because of that, and as it compresses, then the pumping of the heart will be reduced. You'll have decrease in stroke volume, systolic blood pressure decreased, and then the pulse can have what we call wave, which is when you breathe in or out, it will go faint away and then it comes back again. So hypotension, distended neck, exactly what we talked about with the Beck's triad. Usually its treatment is to put a needle into the pericardial space and aspirate the fluid out. You can have what we call acute pericarditis. Acute means just a short period of time kind of thing. It could be, not very severe. Usually it's idiopathic, but we think of previous viral infection can lead to acute pericarditis, which is, sometimes it's called pleurisy, by the way, you guys. So when we call pericarditis is the same as pleurisy, which is inflammation of the pericardial layers. So this presents with chest pain, fever, leukocytosis, malaise, tachycardia, and then friction rub. I want you to underline friction rub because that is that's what we kind of hear under the, when it comes to your auscultation. With your auscultation, you're going to hear that friction rub going. You can hear two leather things rubbing against each other. That's what you're going to hear when you hear the friction rub on auscultation. So chronic is more serious because it involves more of the muscles, not only the epicardium, but the whole myocardium, and sometimes it gets into the endocardium, which touches the visceral pericardium there. So mediastinal pericarditis, okay? So pericarditis, chronic, it sits in the mediastinum, if you remember, the heart. That's where the name comes from. So, you can have what we call mediastinum pericarditis, or you can have constrictive pericarditis, where the pericardial sac becomes dense, non-elastic, and fibrous. And that's, you'll have like rubbing. It's like when you rub against leather. Just take your finger and rub against leather. That's what kind of, hearing, that's what kind of sound you will hear during your auscultation. So infective endocarditis, we talked about it a little bit, which involves the endocardium only. So the endocardium is usually caused by Streptococcus and Staphylococcus aureus. So these are the ones that can lead to an infection of the valves. You can see from the picture here, you have the strep or staph on the valves, and then eventually you destroy the valves, and you will have issues trying to pump the blood and all that. Risk factors would be intravenous drug users, valvular disorders, and then prosthetic heart valves. So you always want to make sure that after you put a prosthetic heart valve, patients do not get into infection. So sometimes you put them on a prophylactic penicillin or so for a long period of time to prevent any of this issue to happen. You'll find this also with implanted cardiac devices, rheumatic heart disease, coarctation of the aorta, congenital heart defects, and Marfan syndrome. So these are some of the predisposing factors. So infective, again, we have manifestation, flu-like symptoms because of the bacteria. Sometimes it can lead to embolization, an embolus traveling from the heart, murmurs, petechiae, and a splinter hemorrhage, that's what they are, just a teeny bitty pinhole type of hemorrhage that you can get. So most of these heart conditions, physical examination, blood culture, you need that because of the bacteria. Complete blood count because you can have increase in WBCs. Rheumatoid factor, just in case the cause is rheumatoid arthritis, you're going to see the antibodies in the blood. Sedimentation rate, which tests for inflammation in general, and in this case, it starts with an inflammation and then it ends up being an infection after that. So you need to treat it. You need to give them some antibiotics and give them, oxygen. The valve, if it's really destroyed, you need to replace it. And if untreated, restrictive can be fatal. So you need to really put these people on medications right away. So myocarditis, inflammation of the myocardium. And we know the myocardium is the middle layer in this case. So in this case, we have it infected sometimes, or you could have it enlarged, inflamed due to unknown reasons. So we don't know why you get myocarditis sometimes, but you get it. So unknown reason could be, and it's not very common. It could be due to organisms like bacteria and so on, can lead to myocarditis. So the terms can tell you where the issue is. It could be if it's endocarditis, endocardium, myocarditis, it's affecting the myocardium, pericarditis, it's affecting the pericardium. So the word itself tells you where is the inflammation or infection taking place. Heart failure can lead to that. Cardiomyopathy, some kind of idiopathic cardiomyopathy sometimes can lead to that. Dysrhythmias, because the heart is not pumping well, that can lead to an inflammation of the myocardium also. So these are some of the manifestations that you can get. Many times it's asymptomatic, and then the patient can walk around, move around until they get that flu-like symptoms thing. And then they start having difficulty in breathing. Then they get palpitation, tachycardia, and other issues. Then under examination, you can hear some heart murmurs probably, and for sure they will get what we call chest discomfort because of that. Syncope would be another symptom that they can get, which is basically fainting. Now, pale and cool extremities, well, we're going to talk about arterial issues where you have cool extremities usually when you have an artery disease. We'll talk about it in a second. So diagnosis is basically the same, with the, sometimes we do cardiac enzyme on them because they increase in number anytime you have issues with the muscles of the heart. You need to identify what is the cause and then start treating it. Anticoagulants if you have clots, antipyretic for fever, Tylenol, SOA if you have fever, diuretics if you have enlargement and there's a lot of fluid involved in this, you can give them diuretics. All right, let's get into peripheral vascular disease. And so peripheral vascular disease, that means we're talking about blood vessels. So you can have issues with the blood vessels, whether it's peripheral arterial disease or peripheral venous disease. Okay, so PAD or PVD, you need to differentiate between them. If the arteries are involved, then it's PAD. If the the veins are involved, then it's PVD. So you need to identify which one is which. As a nurse, you'll be learning assessment, assessing a patient that has either PAD or PVD. You need to separate between them. You can't just, confuse them. I'm going to cover some of that with you here, but you will definitely, when you get to med-surg and other assessment type of classes, you will be assessing the patients more. So here are some of if we talk about PAD, which is peripheral arterial disease, and the arteries are the ones that takes oxygen down to the tissue. So you could easily have a clot there, and if you have a clot in the arteries, you're going to stop the supply going down into your extremities, the lower extremities, and from there you're not going to have a pulse. So think of this. So when you are sending blood down and then your heart is pumping, you have a pulse. So if you have no pulse, when you palpate somebody's foot and you find no pulse, think of probably PAD before you think of PVD. So decrease in rich oxygenated blood, of course, because of that occlusion or spasm. You could have a spasm of the artery also that can lead to that. But usually occlusion or clot can significantly cause this. Ulcers in the legs, diabetics get that a lot. When they have ulcers, it's going to stop the blood flow from going down to your legs, and you're going to lose the pulse there. So anoxic injury to muscles, also any type of irreversible type of injury to the extremities can lead to that. Etiology, we're talking about atherosclerosis is the most common. So that means a plaque buildup in the arteries can lead to that. Obesity, diabetes, uncontrolled hypertension, and smoking. Smoking causes vasoconstriction more often than anything. Then after that, you can end up having a clot. The others are, sensible type of reasoning behind them. So your goal as a nurse is to improve the blood flow. So avoid using heating pads because diabetics usually have less sensation. They have what we call peripheral neuropathy. So when they're diabetic, they already killed plenty of the cells in their feet, including nerve cells. So they have peripheral neuropathy, where they cannot feel it. So if you don't feel a pulse, you do not want to apply heating pads on there because you can burn the skin and the patient would not feel how hot it is. So be careful with that. Because we know that heat promotes the flow. But sometimes you need to be careful when to apply heat. Because if you can't feel your skin, you can burn the skin because the patient cannot complain of the heat. So you need to be careful when you apply. So we have a couple of major peripheral artery diseases that I need you to remember. One is called Raynaud's disease and the other called Berger's disease. So Raynaud's disease is due to an inflammation of the arteries. So the walls of the arteries get inflamed, triggered by the exposure of cold. So if you sit in the cold for a while, you get yourself frostbites, okay? And then your blood supply will go down eventually. Now, but some people, even though it's not very, very cold, you can get that because this is due to vasospasm, intermittent. So all of a sudden you have an intermittent vasospasm in the arteries. So your arteries becomes spastic. So the blood flow will not be too much going into the fingers and the digits. Usually it happens in the digits, like your fingers, your toes. That's where you get it. Okay. Now, you can get what we call Raynaud phenomenon if it is due to an autoimmune condition. So certain people with the autoimmune, like lupus and the other autoimmune disorders, if you get Raynaud disease because of the autoimmune, then you have what we call Raynaud phenomenon instead. So Berger's disease is the other one. Berger's disease is referred to as thromboangiitis obliterans. Okay, thromboangiitis obliterans is the same as Berger's disease, and in this case, we have basically formation of clots. Because thromboangiitis, it means formation of clots. When you form clots due to tobacco, due to smoking, then you have what we call Berger's disease. So again, you look at your fingers and you find them bluer color due to clots that you have in your probably smaller blood vessels. It can occur in arteries and veins, but most commonly in arteries. All right, so as I told you, PID feels for pulses. If there's no pulse, you know it's arterial. Now with the venous, of course, the venous circulation is a little bit different than the arterial. With venous, we're taking blood back into the right heart. So with venous, you have to worry about valves there working. So if you have valves working, then all the blood will go up to your right atrium. But if you have valves not working or inflammation of the walls of the valves, the veins, then you have what we call peripheral venous disease. The peripheral venous disease could be superficial and deep. We'll talk about them in a second. But what you have here in this case, you have insufficient push of blood back into the heart, so everything's pulling back down. So pooling of blood, pooling means accumulation of blood in the, it could be in the superficial veins or it could be in the deep veins. So you could end up having swelling, edema, and all that can lead to this. And of course, you're going to have clots also, blood clots there in the veins, though, not the arteries. So there's a significant difference between venous and arterial. With venous, you're going to feel a pulse because it has nothing to do with the arteries in this case. So to differentiate between venous and arterial, feel for a Pedal pulse is basically by the foot. So if you feel a pulse there, then it means it's venous more likely than arterial. So the etiology, people that are female, that are at higher risk, birth control pills can lead to that. If you remember when we talked about estrogen and the promotion of, aggregation of platelets and all that, and that's where it plays right there. So if you're on contraceptive pills, you're more of forming what we call peripheral venous disease than arterial. Pregnancy can cause this, obesity again, and then sitting or standing for a long period of time. So people that are sitting or standing for a long period of time, usually it has something to do with the veins and not the artery. Advanced age, older people, because they don't walk around, they don't move around a lot, eventually they can get that. So here's a little nursing assessment for you guys that you will be learning and discussing as you get into your clinicals. So, so this is arterial and this is venous, and this is like how we can actually differentiate between them a little bit. If you look at the skin itself, usually if it's arterial, it is cool to touch. So when you feel it, it is not that warm because it's actually deep. But the skin would feel thin. So you feel the skin, it's very thin, dry, scaly, hairless. You're not going to have much hair there. And then you're going to end up having what we call thick toenails. Okay, don't confuse this with fungal toenails. So you get the thick toenails due to the decrease in nutrition. So you have decrease in nutrition coming down into your feet. So here, so you basically they tell you that dangle legs. Okay, so dangling the legs. You feel a little heat in them. When you dangle the legs, feel them. It feels a little warm to the area. But if you dangle them, if you don't, then you don't. It should be very cool. If you dangle them, you feel a little heat, and they look red. If you elevate them, they look pale in this case. Okay. So venous, warm to touch because it's superficial in general, or venous. The veins are more superficial than arteries. We know that already. So it's going to feel warm when you feel the leg. When you feel the area, it feels warm. So if it feels warm, think of venous more than arterial. The skin looks thick and tough. So if you feel it, it's rough and thick. Brownish in color, so it looks a little brownish, when you look at the skin. All right, so when here, your blood supply returning is the issue. So when you return the blood supply in the arteries, that's the issue. Where in veins, the issue is coming down, trying to get, because the veins actually bring the blood up, so you have issues with the veins coming, returning. So here's some arterial lesions, things, locations. Sometimes you have ulcers, and those ulcers are very little drainage in there, not too much drainage. You have tissue granulation there. It looks very pale. Pinkish type of, if it's an arterial ulcer. Where if it's a venous ulcer, it's they have a swelling around that area, and it's very deep, usually deep pink to red when you look at it. So this one is a little pinkish. This one is a little bit deep pink, redder kind of. So that's with venous. So you look, usually you do what we call a vessel when you examine these patients. You look for various position, bring the leg up, bring the leg down, explanation of the pain, where is it, the skin, the color, the temperature, the nails, can sometimes tell you which one is. And then the pulse, of course, again, with the arterial pulse, you don't have a pulse with the artery. Edema, both can lead to edema, but more of what? Venous, because you have return and you have backflow edema more of a vein than the artery. And then the ulcers, again, like I mentioned here, you know, the arterial give you a pinkish kind of ulcer, where a deep red is most likely a venous. You will learn this a lot more as you go on. All right, let's look at superficial veins. So again, we said venous diseases, right, are either superficial or deep. So how can you tell if it's superficial or deep? Well, look at this leg here. Look at the redness area right there. If you get a little redness area around the thigh or the calf or whatever, this is more of a sign of a superficial vein issue rather than deep. So again, you have blood clots going on here superficially in the superficial veins rather than the deep veins. So it gives you that little redness because you have a blockage in certain areas, and then backflow in other areas here in the vein. And then when you have a backflow, then you will cause an inflammation also of the wall of the vein and inflammation of the tissue around it. So sometimes we call that superficial thrombophlebitis. Okay, so you have thrombophlebitis, usually it's superficial. So redness, warm to touch, like I told you, if it's venous, it's more warm to touch. You get a little swelling, tenderness, and also tenderness, very painful here, and feels firm. So when you feel it, it feels a little firm, to touch, and it has that red line here. See those red lines here? You're gonna have like red lines going into the red line or areas, red areas superficially. So what do you do with this? Now you can apply heat, applying heat to the painful area. You're just promoting more blood in this case. Now you're gonna need to be careful with people with diabetic patients, again, because they don't feel the heat, but heat can promote actually the circulation a little bit. You elevate the affected, when you elevate it, then it promotes the blood to go up this way because the blood in the veins goes up toward the body. So when you elevate it, you promote. So elevating feet, depending if it's venous or arterial. If it's venous, you want to elevate. Why? You want to bring the blood back into your heart. So it helps. But if it's arterial and you elevate it, what's going to happen? Instead of the blood going to the leg, it's going to go back to the heart. Then you have an issue. So elevation is more of a venous type of issue. NSAIDs for inflammation, you have a little inflammation there, so NSAIDs could be good. And then compressing stockings. So you put the stocking if it's venous. You don't put no stocking if it's arterial, by the way, because the stocking here is going to push the muscles around the veins, and when they push the muscles, they promote the blood to go back this way up to the heart. So this is usually, it can go away on its own. So you don't really need to too much more often than probably use some NSAID and tell the patient to elevate their legs and put some heat, a little heating pad. Now, deep vein thrombosis, DVT, this one you're going to be looking at a lot as you are getting your assessment going and all that. Now, deep vein thrombosis, you have a thrombus in the deep veins. The deep veins are deeper than superficial. So in this case, you know that you are getting deep into the vein, and when you're getting deep in the vein, you're gonna not bring blood up too much, because all the veins, they bring blood up to the body, and you're gonna have a little bit blood going back. So edema is one of the major things that you're gonna get. So you're gonna get swelling of the legs for sure. So impaired venous return lead to endothelial injury, dysfunction, and hypercoagulability. So you're going to have coagulation taking place in this case. So blood clots could be in there, and then if this is the issue, you're going to swell. Your leg will swell. The calf will swell. So swelling, most likely unilateral than bilateral, by the way. Now, that's how you can tell if it's DVT or if it's right heart failure, for example. If you have a right heart failure, both legs could be affected. because the venous return from both legs eventually end up in the inferior vena cava. And if you have not enough blood going up, then both actually legs you'll have more edema in the ankles rather than in the calf, for example. Because here in the calf, that's where you have the biggest, deepest muscles, right in the calf. And that's that's the most common area where you have DVTs. So cramping, you get cramping pain, usually begins in your calf. Severe unexplained pain in your foot and ankle. Okay, so you're gonna swell up first of all. When you swell up, then you're just gonna start having pain. Skin feels warm, like venous. As we said, venous. Put your hand on the skin, it feels warm, and you know it's venous and not arterial. Skin turning pale or reddish or bluish in color after a while. You're gonna get something like that probably after a while, because even though you don't have enough blood going up this way, you're going to end up having the skin not getting enough blood and not taking enough CO2 out. So when you don't dump the CO2 out, what's going to happen to it? It's going to stay here. It's going to give you that bluish coloration due to the increase of CO2 in this area here. So how do you diagnose this? You do an ultrasound on the legs. So it's called duplex ultrasonography. So you look for the flow and of the vein, you're going to find out that these veins are not moving. You probably have a clot there. Now you're going to end up doing what we call a D-dimer blood test. Okay, and if you remember, we talked about the fibrinolysis and the fragments of the fibrin being involved in when you have a clot. And if you have a clot, then you have fragments of the fibrins, and then D-dimer will be positive for that. So you do a D-dimer on these patients, and it's usually positive. So, so usually when you treat DVTs, usually takes about 3 months to treat it. You can do it inpatient, you can do it outpatient, depending on how well is the patient. Anticoagulants, of course, in both situations. We usually use low molecular weight heparin, okay? If you remember from last quarter, we talked about them. And, you know, and then, so usually you put the patient on an IV. You can do it in inpatient or outpatient, but with the outpatient, you're gonna send a nurse to make sure that the IV drip is going right. And now these days they train one of the family members to help out. But, you know, then you start with, if you're inpatient, of course, you're going to start them with, you know, heparin and then transition to warfarin after that. Okay. And you do the same with the outpatient also. So bed rest, okay, which is aimed at reducing the risk of pulmonary embolism. And that's, I want you to underline and circle pulmonary embolism, because this is the first risk factor, the complication, I'm sorry. This is the most important complication that you can get from DVTs or any of the leg clots type of issues. All right, so this is an algorithm of the vein thrombosis here to come and say, to find out if it's actually deep or superficial. That, you know, just summarizes what we just discussed here. Varicose veins. Varicose veins are the problem where you have a problem with the valves. So the valves, they're incompetent valves. And when you have incompetent valves, so the blood will not flow back up and it will start pooling in here. So pooling, it means you have the blood circulating in this area, not moving up, because the valves are not preventing them from going up. They just keep flowing back here. So you're gonna end up having bumps on the leg. So if you notice a patient with bumps on their legs, probably varicose veins. You could have them in different areas, not only in the legs or arms or so on, most likely in the legs, but you can have varicose veins in the esophagus. You can have varicose veins in the rectum. So this is an esophagus with varicose veins in it. See the bumps in here, those are varicose veins. Again, it's due to incompetent valves that you can have. So we know the capillaries joins, arterioles with venules. And if you're not having the blood moving up through the venules up to the veins, it's going to backflow into the capillaries, and then it's going to lead to leakage of fluid and resulting in edema. So these people are going to have edematose type of legs because of that. Okay. So again, risk factors: genetic predisposition. If your mother or somebody have varicose veins, there's most likely that you can get them. Hemorrhoids, the same thing. Pregnancy can lead to that. Obesity, of course. Prolonged sitting or standing. So you guys need to move, especially now these days. Don't sit on chairs and sofas and all that. Move around. Go walk around a little bit. Alcohol abuse can lead to that. Liver disorders, esophageal varices. That's, alcohol abuse and liver disorders have something to do with this. Esophageal varices. Constipation can lead to hemorrhoids. So you don't want to be constipated because you're going to end up having hemorrhoids. So what do we do with these? So they're going to look like this, these little bumps that you see here. So if it's superficial veins, you're going to look like that. So these are like little superficial vein issue that you can get. Or you can get deep ones, which is the bubble, If you get bubbles, that means it's deeper than superficial. Will give you like just those spider veins type of, looking. So it's more likely, you're not walking around much. So elevate your legs because you need to promote blood to go up to your heart. Compression stocking. So when I put the stocking on here, it's going to push these bubbles in. It's going to promote the muscles to push the blood back up. So stocking would be good. So stockings are good with venous, but it's not good with arterial, by the way. Why is that?
Because with arterial, you're having a problem getting the blood down. So the stocking is going to keep the blood from coming down. And with venous, you're trying to prevent the blood from pooling at the bottom. So the stocking actually helps push it up to the heart.
Absolutely. Absolutely. If you have venous and if you put the stocking in, you're going to stop the blood from going down, even though it's very slow because you have clots and all that. So you're going to stop it even further. So, stocking is usually for venous, not the arterial. So avoid standing long, sitting, exercise, all that stuff. Okay. All right. So here are some of the things that you need to avoid: constrictive clothing. So if you have, anything that is, if you have arterial in this case, you don't want to wear tight stockings or tight, pants or whatever it is if you have arterial issues. Again, avoid extreme cold if that causes vasoconstriction. Quit smoking. Avoid knee flex position, okay, or crossing legs. When you do that, you have the blood staying in the same spot instead of pooling. So you wanted the blood flow to move around. When you cross your legs or you have a knee flex, then you're stopping the blood from flowing. So you always relax your legs. Antiplatelets, anticoagulants, medication that lower cholesterol, all that, you can do all this. Now, I want you to, we're going to talk about intermittent claudication in a second. I'll leave it until we talk about it in a second here. So exercise program, walking, always walk around, to avoid intermittent claudication, which we will cover in a second here. Skin care, always apply lotion, apply all that good stuff to promote healing and promote the vascular flow within the legs. The shoes, make sure the shoes is not very tight on the legs of the patient, right? Heating pads, consider it to promote the flow, but if you have arterial, again, and think of neuropathy on these patients. So don't apply the heat because you're going to burn the skin more. So we've seen people putting those heating pads on people that have arterial. You don't just apply the heating pad onto patients as soon as they come and you think of them, they're clotting down leg. You got to differentiate if it's venous or arterial before you put it in. Arterial, you don't want to put it on. And usually, if you have a clot and you put that a lot, you're going to break that clot and it's going to move up to the lung, and then you're going to end up having pulmonary embolism. Betsy, you work at a hospital. You know, you've seen maybe pulmonary embolism would be one of the major type of complication with people with these type of issues, right? They die because of that.
Yeah. I also tell like they don't like not to like massage or touch the area until like they diagnose it.
Yeah, unfortunately, sometimes the way we do things can kill the patient. So you guys be careful of what you're doing here, because you can have peripheral disease, you know, in the legs, arterial or venous, and if you apply too much heat, what's going to happen? You're going to break the clot, and the clot's going to eventually go as an embolus up to your lung or up to the head. Because you get a stroke, you get a heart attack, right? Because of the heat that you applied. So be careful. You know, some patients will come to you and say, "Why don't you put the heat on?" We'll explain that to them. Then they'll be quiet. All right, aneurysm. Yeah, ballooning, right? So you can have a balloon, and usually it's a weakness of the wall. So you have weakness of the wall of the artery that leads to these type of aneurysms. So it says you have a saccular aneurysm, fusiform, and then ruptured aneurysm. So fusiform looks like yes. Oh, I'm sorry. Go.
Oh, sorry. With the nursing interventions, I just wanted to make sure, was that both for peripheral veins and arterials, or is that just for
what?
The nursing interventions you just went over?
Both.
Okay.
Yes. Thanks for letting me know. Yeah, they're both. You know, this is just to be careful. You know, we already covered which one is which. So this is like a mixture of both.
Okay,
you know.
thank you.
Good point, Stephanie. Good point. All right, so with these guys, with these aneurysms, so if I have an aneurysm like this, I'm going to move the blood moving, and then eventually I'm going to have pooling again. So I have pooling right there. When I have pooling, more pooling, and more pooling, and eventually it can rupture. That balloon will rupture. So weak wall can lead to this. So we have true aneurysms, right? So these two are true aneurysms, and then a false aneurysm usually do not affect all the 3 layers of the vessels. Okay, so if you remember, the walls of the vessels are, who wants to tell me the 3 different layers of the walls of the blood vessels? What are they made of? What are the 3 layers?
The intima, media, and adventitia.
Good job. Tunicas, yes. All right, so if it does not involve all 3 layers, then it's a false aneurysm. If it involves all 3 layers, then it is a true aneurysm. That's the difference between them. Then you have what we call dissecting aneurysm. That's basically when you bleed. Okay, so hemorrhagic aneurysm or dissecting aneurysm, because it just ruptures eventually. So dissecting, it means the ability for it to burst. That's what dissecting aneurysm means. All right, so when can you get aneurysms? Congenital defects can give you aneurysms. Atherosclerosis, hypertension, dyslipidemia, diabetes, tobacco smoking, advanced age, all that can lead to aneurysms. So it depends on the location and the size. That's the manifestation. So you can have aneurysms in the brain that will give you headaches, of course, right? And it gives you pain, crazy pain. If it ruptures, then it can lead to strokes and it can lead to other issues. If it's in the abdomen, then you have, like, you can hear a rumbling sound probably in the abdomen while you're auscultating. All right, and you know, maybe asymptomatic. You could have it and there's nothing there. Sometimes you feel a pulsating mass, by the way. So when you palpate, you put your hand on the abdomen and all of a sudden you feel a little pulsating mass. that would be an aneurysm, probably, most likely. Sometimes you have respiratory difficulty because of the less oxygenated blood reaching the tissue, of the lungs also. It depends on the area again here. So physical examination can diagnose this, X-ray sometimes, echocardiogram, CT scans, any of these that you do. Arteriogram would be good, because you can see the aneurysm. Treatment, usually it depends on it. Sometimes we leave it alone if it's not very significant. But if it starts causing trouble, we need to do surgery. You need to take it out. And you rather get it before it ruptures. Because as soon as it ruptures, you can die because of that. People die of ruptured aneurysms. All right, hypertension. I'm not going to spend a lot of time on this because I did cover it when we talked about antihypertensive drugs. So let's zoom through it real fast. Systolic blood pressure, diastolic, we know all about it. We know about all that stuff, preload, afterload, and all that. These are the different variation of blood pressures. We've talked about the regulations when we discussed the heart in general. So you guys are very familiar with this. So I'm not going to spend time on it here. The angiotensin. So the 3 different types of blood pressure. You can have mild, pre-hypertensive, hypertension. Malignant is greater than 200. We discussed that when we talked about antihypertensive drugs. So mainly when you have primary hypertension, what is this? Primary hypertension is usually is caused by, like it's unknown etiology. Okay, so primary, if it's we don't know why, but we can blame it on all these things here. Okay, so we can blame it on family history, we can blame it on age, we can blame it on ethnicity and genetics. We can say stress does that, that's why you have hypertension. Now, not everybody, we're all stressed out, aren't we? So it doesn't mean that, oh, well, you're stressed out, that's why you have hypertension. But it does give you hypertension. We know that already, we discussed that. But many people, are stressed and they don't have hypertension. So it depends, so these are modifiables. That means if you modify these things, it can reduce the chance of you getting primary hypertension. But the main etiology of primary hypertension is unknown. It's an unknown reason. Pregnancy, endocrine tumors. Now, if these significantly causes the hypertension, then it becomes secondary, okay? Now, if this is known, then, like you had this, and then eventually, Cushing syndrome, and then you have hypertension, then hypertension becomes secondary and not primary, So these are, that's why we call them modifiables, rather than the primary cause for them. Okay. All right, so we call that the silent killer because we don't know when you get that hypertension. If you diagnose it, then you have it. We can't pinpoint something to it, but if you have it, it can really kill you if it's not controlled. It's called the silent killer because many people, they have no feeling whatsoever, it's asymptomatic, and then eventually they die of a stroke if it's malignant. It can lead to end organ damage. If it's not treatable again, or if it's not controllable by medications or anything like that, it can ruin your kidneys, it can ruin your heart, it can ruin a bunch of different organs also. So you can have, you can end up having left ventricular hypertrophy. We talked about, different type of hypertrophies of the ventricles. Blood pressure can lead to that because the heart is trying to pump more due to the increased afterload that you have from hypertension. So you magnify the you increase in the number of fibers in the ventricle. So all these can predispose to primary hypertension. So we say if you have hypertension, we come and tell you, why don't you modify your lifestyle? That's the first thing. Lose weight, exercise, DASH diet, Anybody have an idea what's the DASH diet?
It's a low sodium diet,
Yes.
basically.
Yes. Yeah. So alcohol moderation, decreased sodium intake in general. Drug therapy for hypertension affects heart rate, you know, stroke volume, rate, and then stroke volume, systolic ventricular rate, SVR. All right, secondary, it means what? You get hypertension because you already have something else. So these are the other things that can lead to hypertension: renal artery disease, stenosis, pheochromocytoma. Anyone knows what that is? Pheochromocytoma?
Isn't it a mass
Is that a
on the kidney?
Yes. Yes, you do have a tumor of the adrenal gland in general.
Oh, yeah, adrenal gland.
That's fine. Very close. Pregnancy can lead to that. Obesity can lead to that. Sleep apnea can give you this, by the way. And then even hyperaldosteronism, most common cause. So hypertensive emergencies, again, hypertensive crisis, malignant hypertension. We're talking about 200 over 120. So if your blood pressure is higher than 200 over 120, then it's very high. You know, you should not be walking around with something like you know, like that, especially if it's untreatable. So these are conditions that you can get if you have high blood pressure, brain, CVAs and all that, retina, myocardial, heart, blood, elevated blood sugar, you know, kidneys again here, hypertension and all that. So you can get any of these diseases if you are not treating your hypertension. So hypotension is the opposite. That's basically low blood pressure. And usually if you don't want, usually you want the variation or the pulse pressure to be within, you know, no more than, do you know what a pulse pressure, you guys? Anybody? What's a pulse pressure?
It's the difference between systolic and diastolic pressures.
Yes, yes. So the difference, what is normally the difference between systolic and diastolic roughly? Between what and what?
40?
Yeah, 30 to 40. So between 30 and 40, you're fine. You know, if you're like 110 over 70, 120 over 80, you know, even if you're 110 over 80, you're fine. But when it hits lower than that, so if it's lower than 30, okay, if it's less than 20, then you're in trouble. So you always want it to be within that range. So hypotension, you're diagnosed with hypotension if your systolic blood pressure goes down below what, you think?
Below 90?
So 90 is the limit, right? So we look at 80 as the number. So you can go up to 80, down to 80 systolic, but depends on you also. If you're older, we worry about you, you know, but if you're an athlete and so on, you go 80, then, you know, you're fine. But anyways, 90, yes, 90, you don't want to be below 90. What about diastolic? What's the minimum that you can go?
60?
60 is the minimum, but you go below 50. So below 50, we worry. You know, now you're looking at people. But 90 over 60, yeah, this is the minimum that you can go as low blood pressure. But when are you diagnosed with hypotension? Then, you know, like 80 over 50. That's how you look at it. All right, so these are the different things that can result in hypotension. So low blood pressure, and you know, people passes out. I mean, passes out. People, yeah, they faint, syncope. You know, you can faint because of this, and shock and syncope, they go together. So here, problem with vasomotor or baroreceptor response. Who wants to elaborate on this?
Repeat the question.
Who wants to elaborate on problem with vasomotor or baroreceptor response here? How does this play into hypertension?
Oh, it's just the heart is having a hard time detecting the distribution of pressure, so that it can mess with the compensatory responses.
Good job, Aaron. That's fabulous. You know, because the baroreceptors are the ones that can measures not only the amount of oxygen that you have, but the pressure. You know, your blood pressure kind of sensors. And if you remember, we talked about the epinephrine and all that. You know, going through the baroreceptors, and that's exactly what happens here. So if they are not getting a message that it is low, then you have an issue here. Then we have drug therapy also can lead to hypotension, arterial stiffness, volume depletion, secondary disease process, vasovagal reaction. All right, vasovagal, what is this?
Does it have to do with the vagal nerve that like stimulates the heart?
Yeah.
Or the vagus nerve that stimulates the heart?
Absolutely. The vagus nerve, sympathetic nerve stimulating the heart to beat. So when does this kind of, like you have a negative feedback on the vagus nerve, usually fear does that. Now, how many, you know, you're probably going to see people when you put the needle in them, you know, doing IVs or draw their blood and they pass out. That is called, you know, vasovagal reaction, okay, because of that. And cardiac dysrhythmias also can lead to this. All right, so hypertension, medication, we know all about it, just restricted diet and all that. So shock, going into a shock, that means what? You have less oxygen reaching the brain. That's it. So whatever causes less oxygen to reach the brain, eventually you're going to go into a shock. There are different factors that can lead to that. We have the heart that is called cardiogenic. We have a blockage in the artery can lead to that if it's central, okay? If it's peripheral, you know, we can hypovolemic, like, you know, less blood, you know, bleeding can lead to hypovolemic. If it's external, if it's internal, you know, fluid loss, you know, within the body for, you know, it could be internal bleeding. You can lose fluid. Dehydration can lead to that. Anaphylactic exposure to an allergy can lead to that. A septic, a bacteria can lead to that. And neurogenic, which is basically being afraid. And when you are fearful, then your parasympathetic takes over, and then it can result in you being going into a shock. So this is just a mechanism of going through the whole thing. You know, similar to what I discussed here. You can spend a little time and make sense out of this as we go on, and it'll make sense to you. So eventually, you have less oxygen reaching the blood, impaired oxygen. You have hypoxemia. Hypoxemia eventually it leads to less anaerobic metabolism, and when you have this, then you produce lactic acid, and then you have less ATP, inhibition of the potassium pump, and hydropic swelling, and impaired membrane integrity, and then you have a cell death, and the same you know, mechanism here eventually takes you. So all that is caused by what? Low oxygen. So again, low oxygen can be caused by toxins. So you have a septic shock. If you know, bacteria can attack, they usually release these two factors here. That increases in the nitro oxide, and with that vasodilation can cause hypotension. Pathophys, again, you can look through this and make sense out of it. It all makes sense. So these are typical of manifestations if you are in a shock. You know, you have increased respiratory rate to compensate, decrease urine output because you don't have enough fluid in there, increase specific gravity of the urine because you are dehydrated in this case, so the concentration of the urine will be up. You know, the cool legs basically because you don't have enough oxygen in the tissue. All right. So you go into hypovolemic shock. Cardiogenic shock if the heart is the cause, then you end up go into hypovolemic shock, which is hypoxemia. So you can see that it makes sense out of the whole thing. It makes sense. Myocardial failure, decrease ejection fraction, increase end systolic volume. What is the end systolic volume again?
Isn't it the volume of blood after systole?
Yes, absolutely. So think of
Preload, right? Too.
what's that again?
Isn't that also like the preload?
The preload is the amount of blood that you have being pumped.
Oh, sorry. Did you say systolic volume or diastolic?
End systolic. So end systolic, yeah.
Sorry.
That's okay. So end systolic, it means before you eject, you have a little blood left in the ventricle, and that is referred to as the end systolic volume. All right. So, so of course the preload will increase because it back flows. You know, everything back flows to the right side, so your preload increases, and then increase left atrial pressure. We know that already because again, everything kind of back flows. Increase pulmonary, right? Because you have increased pulmonary congestion, hydrostatic pressure, and then eventually hypoxemia. All right, so septic, the same thing here. You know, you can make sense of this. Just sit there, spend a little time on it. It'll make a lot of sense. So compensations, this is how you compensate on things. Again, we said the adrenal gland can compensate. The sympathetic nervous system can compensate. The RAAS can compensate also. And we understand how we compensate through these things here. So just look at them and then it makes sense. Makes sense. All right, this is one way to assess shock, you know, class 1, class 2, class 3, or class 4. We look at different aspects of things we can, you know, so pulse rate, less than 100, but it's, you know, if it's class 1, 100 to 20 systolic, pulse rate, I'm sorry, pulse. So everything kind of decreases with the pulse pressure. Yeah, so you become pale, peripheral central cyanosis, delayed capillary refill. You know, so just think when you think of shock, everything dilates, blood pressure goes down, pulse rate goes down. That's how you think of it. Pulse rate actually increases because you're compensating, right? So pulse rate increases to compensate. So you know, heart rate increases because you're compensating because you don't have enough oxygen reaching your tissue, so automatically your pulse will go up. All right, so this is treating the shock, treatment of shock. So all these shocks here, you know, depends on the type. Sometimes supportive, sometimes we have to give them oxygen, in this case cardiogenic, cardiac drugs to promote contraction of the heart. Septic, we need to take care of the bacteria by administering antibiotic. Hypovolemic, you need to stop the bleeding or give them fluid if they don't have enough fluid there. So positioning, if you remember, you lift the legs up. Why do you lift the legs up?
to promote blood flow back up to the heart.
Yeah, that's the whole idea. Promote blood flow back to the heart, so oxygen will. Another way is to bring your head down. When you bring the head down, you promote the blood to go down into your head. So either head down between your knees or the legs up. Okay.
I thought they said that reverse, is it called reverse chun? I can't remember, but that position where the head is down and the legs are up, I thought they were saying that actually like ended up causing like brain damage.
In certain situations, yes. It depends on what situation you're in, so, but if it's just the normal hypovolemic, yes. Okay. So if it's just the regular hypovolemic shock type of shock, where you pass out, especially, if it's like neurological shock, okay, you pass out because of needle, afraid of a needle, you're not going to cause much, and you bring their head down. How many times do you bring your head down? Are you going to have brain damage? It depends on how long, right? I mean, you keep, if it's a tumor, all right, or if it's something that you think of something else but in general, you're talking about moments, not all the time, right? Just to bring the guy back. And that's the whole purpose of this. We're trying to bring the guy back. So it's fine, it's fine. All right, let's talk about congenital heart disease. Congenital heart disease are mainly problems with your valves, with your septum, with all that. So we have two types. We have acyanotic and cyanotic. Acyanotic, that means they don't cause blue coloration. Cyanotic means it causes blue discoloration of the skin. So discoloration of the skin due to the increase in CO2 going back into the oxygen. So when you have deoxygenated blood mixing with oxygenated blood, then you have an issue. Then you're going to have cyanosis in the patient. So these are listed here. We'll cover as many as we can out of this, but just think of this here, left-right shunts. So if you have a septum defect in the ventricles, or so ventricular septal defect, you have. So let's list them for now, and then we'll go over them one. About ventricular septal defect, patent ductus arteriosus, atrial septal defect. All these are left to right shunts. Okay, so you're going to end up having oxygenated blood going into deoxygenated blood. So think of cyanosis here.
Dr.
Acyanotic with left to right. Yeah, left to right.
I'm sorry.
Go ahead.
I'm sorry to interrupt. So we have like 15 minutes of class left and about 50 slides. Are we still having this exam this weekend, covering all of this material?
Well, I was gonna, I was gonna go a little further than the 2 hours. So I will have I will finish this. If you really have to go, you can go. I will just record this because it's not the slide number more often than the concept in it. If I, I need to finish this chapter. If I don't, then I'm behind for next week, because next week we're going to do, fluids, electrolytes, acidosis, alkalosis, and all that. So you can listen to the recording, with your time. I mean, you still have like 5 days. So you can take it on Sunday, the exam, if you want. You don't have to take it tomorrow or,
Okay.
Let me see here what we have. Yeah, because after the congenital heart disease, it will be EKGs, I think. And the EKG, I already covered some of it, but we're going to look at the arrhythmias basically in general. So, yeah. Let's see what we got here. So these are the different, yeah, this is EKG starting here. So slide 1. 43. What I will do is I'll just, because some of this stuff you already know, I don't have to go over it. I'll just mention this a little bit briefly and then get into arrhythmias. This is just the axis and so on. So, yeah, let me continue and finish. See if we don't take it this weekend, it'll be too much for you during the weekdays because you're already studying for other things. That's why I wanted you to, you can listen to the recording, depending on your time. So if you can't stick around, that's fine. I will just finish it. I need probably 30 minutes more, by 2:30 I should be done, 2:40. So you can stick around if you want, or if you have to leave, that's fine. I will have a recording going for you. Okay. Any other comments, you guys? I mean, is that okay with you guys, or what do you think?
I was just asking, just because for me personally, I feel like it's a lot of material to cover. So I just wanted to make sure that we still have the exam this weekend. But that was just me personally.
No, that's everybody probably. I mean, the material is huge. I know that, but that's really being very strong. If you know this stuff, my God, you guys, you can be very strong all the way across. When you get to your assessment, when you get to the NCLEX and all that, this material is everything you need right here. So I rather finish it, and cover it. And the other systems also, some of them are like the renal, they ask a lot about acidosis, alkalosis, and then when we get to the respiratory, I need to cover that because these are essential type of systems there. I can cut down maybe at the end with the endocrine stuff and all that. I can cut down at the end, but these things are probably the most important topics that you need to know of. So. Okay, let me see if I can finish and what I finish here, and then we'll go from there. So let me see if I can, I need about maybe 40 minutes, we can do this. So. All right, so congenital heart diseases. Again, we are talking about defects. So let's look at this first. This one is atrial septal defect. So that means these are the atria right there, and you have a septum, you have a hole in the heart here, right there. So we know that if you're born with this hole in the heart, we know that here is deoxygenated and here oxygenated. So when the left ventricle pushes the blood out, eventually you're going to have some of the blood flowing, from here back into this. So you have always a left to right shunt. Okay, so when you have this, you're going to have a little mixture of the oxygenated blood here going here, but it's acyanotic because it's not significant. The amount of blood that goes in there, it's not major. So here you see that this one left to right shunt, but it's acyanotic because it's not much blood, oxygenated blood shooting in there. This one, if you have an obstruction, like pulmonary stenosis or aortic stenosis, any of these things, coarctation of the aorta, I'll talk about it again. That's the connection between the aorta and the pulmonary artery and how the blood flows in there. It's acyanotic because it's not much blood, oxygenated blood shooting into the other side. These are cyanotic because you have plenty of oxygenated blood shooting to the opposite side. So it's the amount of oxygenated blood. That's how you look at them. So ASD, this is the issue here. We have secundum or premium. So this is, basically if you have the one on the top would be secundum. And if it's, so it depends on the, whether, how big is the hole, right? So, or if it's one septum is longer than the other. So septum perineum, one septum is bigger than the other. This one is both septums kind of equally, okay? But that's what we're going with this one here. So with these people, the only thing you want to remember is this mild growth failure that you can get with these kids. So ASD can give you mild growth failure, okay? Again, it's acyanotic. Treatment, you need to do surgery on these patients, so you have to take them into surgery and close the hole in general. You can do surgical catheterization closure, either with a catheter or you open up and you go ahead and close the hole in there. Ventricular septal defect, ventricle right over here. So you have blood flowing from the left ventricle back here again. But again, it's not cyanotic because not enough blood goes in there. So that would be the second one. So we have different types depending on, four different types. So perimembranous. So this is the common. This is the most common. That means it's within the membranes, of the septum. Infundibulum, which is right over here. So infundibulum would be just below the fundibulum, which is subpulmonary. So this is your pulmonary artery right over here, just below it right over here. So subpulmonary or infundibulum would be this one here. So membranous would be just the membrane that is involved in this case. Muscular, the whole septum is open. And AV canal, this is the one that if you have it just barely away from the, a little bit more into the ventricle, so it depends on the location. Also, that's how we refer to them. Muscular are down here, AV canal is over here, subpulmonary is over here, membranous are over here. So it depends on the area where they are. It could be small, could be moderate. It depends on the size that you have there. What kind of murmurs? It depends on the movement of the blood during systolic or diastolic. Usually, when you eject blood, you eject it during systolic. So, but you hear the murmur during the diastolic. When the valves closes, you'll hear a little rumbling going, and that rumbling that you hear is due to that shift of blood from the left side to the right side. Right. Most of these, treatment would be surgical. So I just want you to remember that there are surgical treatment for most of these defects in the septum. So atrioventricular septal defect, that's the, if you have a defect between the atrium and the septum. So we know this is the atrium, this is the ventricle. If you have a defect between them, between the atrium and the ventricle, then you have atrioventricular septal defect. So it depends on the defect in this case. It's only about 4% of the population that has this. And again, you need surgery to take care of that. And it's usually the incomplete fusion. Most of these, they're due to the incomplete fusion of these septa where you have them. Now, I want you to remember one thing, that AVSD is more common in Down syndrome. So remember that for the test. So AVSD, atrioventricular septal defect, a lot of the Down syndrome kids have this. So out of all that, I want you to remember failure to thrive, because this is the issue where these kids they fail to develop. So you'll find them very, they're infants still, but they're, the way their weight and their growth is way below the normal growth of other infants in their age. That's how you look at things in general. All right, so surgery is always required. Always check their weight. So failure to thrive, if it's less than 5 kilogram that they're growing within a certain time, then you know that there's a possibility of that. So patent ductus arteriosus, that's the defect right there. Between the pulmonary artery and the aorta, you have a little canal usually that opens up before, during your fetal stage. And you have what we call a ductus arteriosus right in here. And when the blood flows up there, then you have oxygenated blood going back into the pulmonary trunk. Again, it's acyanotic because not enough blood goes in here. I want you to remember that that also, these torch type of infections, okay, which are, many of them has something to do with rubella, okay. Kind of very common in PDAs. So just connect rubella with PDA.
Dr. J, what does TORCH stand for?
I can't, I can't recall, honestly. I have to think deep about this a little bit, but I will get back to you for sure on this. It just skipped my mind right now. All right, I'll get back to you. So coarctation of the aorta. This is basically when you have narrowing of the aorta. So if you see here, we have narrowing of the aorta, and when you have narrowing of the aorta, then you have less blood shooting up here, shooting down in this case. So that's what, so you have less. All right, so let's see here. I'm dragging here. So, all right, so let's have another day for this before should we probably give you the test on Tuesday instead, or Wednesday? On this, so pharmacology will stay over the weekend, and this one I can probably move to maybe what day would you like it? It's got to be during the week, though. It could be a day or 2 days, maybe.
Tuesday, Wednesday?
Tuesday, Wednesday.
Yeah, that's fine.
Okay, so we can do Tuesday, Wednesday for this one. But I will finish this on Monday, and I'll start the new chapter, just to be careful. But study over the weekend for this, okay? Don't wait for that day to come. You know how, the material is a lot. I just need to finish it, though. So we have maybe 50 slides that I'll finish within maybe 30 minutes or 35 minutes. And then I'll start the renal structure. So let's move this test to Tuesday and Thursday of next week. Okay, so Tuesday and Wednesday, Patho. Okay, yeah, after 2 hours at, in the afternoon, I'm usually out of it. Okay, so good. Yeah, we'll stop here. We'll stop here, and I'll cover this on Monday when I see you guys. So we'll finish this, and then I'll cover the rest of the, but I have to get into the body fluids and so on when we get there. Good enough?
Yeah, sounds good.
All right, guys. All right, I'll see you. Study hard. Let me know if you have any questions. Send me an email. But study this material over the weekend. Don't wait, because it's a bunch. So study like the test is this weekend, but we're just postponing it 2 days. That's all the test. So study like it's really, on Monday, the test, or Sunday. Okay?
Okay.
All right, guys.
Good, thank you.
All right, all right, Stephanie, bye. See ya.
Dr. J, I was wondering, did you get my email about the assignments that are going to have to be due?
To improve. You know what? Was it in pharmacology or this one here?
This one.
This one here?
Mm-hmm.
Okay.
Yeah, because I know the focus points are, obviously
let
due.
me see. Maybe I'll give you a research. Yeah, the focus points are okay, but are you very close? Is that what it is? You have now. Let's wait until the end. Maybe if you're very close within 0.5 or so, 0.6.
Oh no, I wasn't talking about the end of the quarter. I was talking about for this exam. Because I noticed that when I looked under the study guide section, it involved EKG worksheets that had the answers already. So I wanted to know if those were due as well as the focus points for this exam.
Oh, the focus points? Oh,
yeah.
Okay.
Yeah, just the focus points for this exam.
Okay, let me look at that in a second here and see what we have. Yeah, I just looked up torch again. Toxoplasmosis, others for O, rubella, cytomegalovirus, and herpes. So these are like maybe STDs, a bunch of STDs going. That's what it is.
Can you repeat that again?
I said torch stands for toxoplasmosis, then O stands for other, which would be syphilis and varicella, and R for rubella, cytomegalovirus for C, and herpes simplex for H.
Okay, that makes sense.
Yeah, so let me stop here.